So we were doing breech deliveries, and that comes out. And once a month, we used to meet together, 5 or 6 gynecologists at LaSalle, and we had regular meetings every Thursday morning with the staff. And we said, what we're going to do? We said, we're going to continue because we don't have these bad effects. I called the neonatologist at the Royal Victoria Hospital, Dr. Bob Usher, and Papa Georgiou, who was the head neonatologist at the Jewish General. And I said, what's your experience in Montreal? Is this a problem of doing? He says, when it's done properly, it's not a problem. In other words, it's what I believe. If you know how to do it and you respect the forces of nature and work with a woman, then you're not going to have some problems. Obviously, you're going to have more cesarean section than somebody that has a presentation head first. Mm-hmm. But that doesn't mean that a large majority can have vaginal birth.
And when did you talk to him about that?
That was, you mean for the complications? That would be in 2002, 2003.
Yeah. Okay.
So we didn't change our practice on that.
Right.
But we were at risk because, as you know, internationally, if you do something new and you get in trouble, the medical societies will be against you.
It wasn't really new. It's just that it was
counter to what was practiced.
Counter to the term breach trial findings, yeah.
And I must say, in truth, and when I was training at the various hospitals in Montreal, I've seen some, breech birth that was not very nice or not very well done. But one of the main teachers who taught me that was an Egyptian doctor, Dr. Aswad from Montreal, and he was fantastic. So I knew that I could do it. So, and then in my training, I spent a year in Boston at the Harvard Medical School, but our hospital for obstetrics was the city hospital. And so as a resident, we were doing hundreds and hundreds, I think I did 1,100 deliveries or something in a span of a year. So forceps, breech, twins, we all did that. There was no other way.
Andre, I have a question for you about forceps. How often did you need forceps?
Oh, forceps, I would think in our practice was probably around 5 to 7%. And it very dependent on the type of woman and, who were coming to have birth. Like in Boston, it was very high gravida, woman who had 15, 20 babies. So no muscles, the baby was stuck in occiput posterior and transverse arrest, and there was no way in them days, I'm talking 1970, 71, that you would do a cesarean section. The more women had experience, and depending where they came from, they delivered easy or difficult. But when I was in LaSalle, I was influenced on changing things for birth from my own experience. Like my wife and I got married when we were in medical school. She had a baby a year later. And at the hospital, I could not come close to the baby, even during the delivery. Finally, the professor said, let this guy come in, he's a medical student. Because I was still only a medical student. And the sisters used to say, don't touch, you're not sterile. So I turned to the sister, very upset one time. I said, sorry, I'm not sterile, I'm the father of that baby. So she didn't bother me after that. But I swear to you that when I came home, I don't think I had touched the baby after 3 or 4 days in the hospital.
Wow.
So I promised myself, once I become in that specialty, I'll do my own things. And I was influenced by a woman who came from other cultures. I had friends. I traveled to France at that time when I started practice. And by the way, I was named chief of obstetrics at that hospital 3 months after I arrived there.
At LaSalle?
Yes, 3 months. But I had a group of nurses who were fantastic. Everything that I wanted to change, they agreed. Or they even brought changes to me, and I agreed to what they were suggesting.
It was LaSalle that was the main hospital that I approached when I came with all of the information from Frankfurt.
Oh, yes.
And they accepted me to come and present what I found there.
Oh, yeah. Dr. Fortin, Yipa Gagné, these were fantastic physicians. So we decided to change. First of all, we, the 5 physicians, bought a birthing bed. Because obviously the government and the hospital didn't want to do anything like that. So we paid, I think, $5,000 in them days to buy a birthing bed, converting a room into a birthing room. And then the first thing we did is, well, they wanted to make rules. You know, a diabetic woman cannot go to the birthing room. I said, no, anybody can go to the birthing room. Diabetic, twins, whatever. Then the problem occurred that we didn't have enough, so we made a transformation, got a government grant to transform into 5 birthing rooms.
What year was that?
That was in 80s.
Okay.
And then we had 5 birthing rooms, and then we changed we made a plan to what they have now, to have only birthing rooms, no postpartum, no nursery. Everything
that was just
happens.
around the time when the midwives were starting to fight for legislation.
Yes. And well, at that time we had 2 midwives who used to come to the hospital, and the only rule I had for them, because I said one of us has to be at the hospital.
So midwives that were legislated or not yet?
No,
Still in the 80s, okay.
They were
legislation
doing it in the countryside like Châteauguay and these places.
Yeah.
So, and then I slowly, and because after the FIGO meeting, I developed close ties with FIGO, and I become head of the Maternal Fetal Medicine Committee.
Aha, when was that?
And that was probably towards the end of 98, 99, just about 2000. And I stayed head for 6 years, and then post head for another 3 to 6 years because they wouldn't let me go. Today, the terms are much shorter, but my term was quite long. And that's how I met Pius Okong and got involved with Uganda, Guatemala, and Haiti.
Right.
We partners with these 3 countries.
Yeah.
So that's how I got involved with FIGO.
Okay, so let's go back to the term breach trial. So I just wanted to give you some of my memory, okay, of what happened. So the story, it was published, and then when did you first hear about? Well, first of all, when it was published, what was the reaction at the SOGC?
Not much. I think there was a mixed reaction. I would say that there was not a majority or minority. I mean, people were concerned, and a lot of people on the board came from hospitals where they immediately converted to all cesarean section.
Right.
The Quebec group, no. That's what made the difference. The Quebec group said, no, we're not going to ban vaginal delivery for breech deliveries.
Interesting, right.
So, and I think out west, there's a couple of them out west also. And I'm not sure about Vancouver, probably, because Dorothy Shaw would know.
Maybe women's.
Yeah, women's hospital. So we had a mixed thing, and we wanted to make a guideline, which I talked to you on the phone, is that we wanted to make a guideline on breech vaginal delivery. But in SOGC, there were 2 obstetrics committee. The clinical obstetrics committee, which is mainly aimed at normal birth and low risk birth, but still recognizing the complications, treating. But there was also another committee called Maternal Fetal Medicine. That's supposed to be the highest specialty in the practice of obstetrics. They didn't want to do the guideline. It took me about a year or 2 to convince them to do a guideline on breech. And the way I got them to agree is I said, okay, you don't want to do it, I'm going to have this guideline done by the clinical obstetrics committee.
Right. So this is after 2004.
Yeah, that would be about 2006, about 7.
Okay, because I remember getting the call from Dorothy Shaw.
Yeah.
This is what I remember when I was working for you. So we're talking about 2004.
Yeah.
And I get a call from her, and I go, hi, Dorothy. She goes, have you heard about the term breech trial? And I said, yeah, I've just been getting some little tidbits about it. She said, what have we done to women? What have we done to women?
Oh, yeah.
And I went, so I investigated a little bit more. And of course, you and I were involved in the international work, but I read more about it. I read some of the things that Andrew Kotoska had written. I read the trial again. And Ken and I had actually done rounds in 2003 at the General Hospital because we were concerned about the fact that they were basing their determination and the way everybody was practicing on one randomized control trial. And we had just been to Oxford, like in 1991, like just within 10 years, and they really base everything on meta-analyses and systematic reviews. Sure. This was one randomized control trial. So we were saying, this shouldn't be changing practice the way it is. And there was already, you know, a lot of concern about it from the Kiers from the Netherlands. He had written an excellent paper talking about the fact that, you know, there's a lot of there's something going on here, because there's not a lot of these babies that were born vaginally in the NICU. So if they're not in the NICU for very long, there doesn't seem to be a problem with them. So what's up, right? And that was all, he wrote that in 2003. But it wasn't until 2004 that they published the follow-up to the term breach trial. So that is when I remember talking to you, and I remember going down to your door. I remember knocking on and saying, Andre, we got to do something about this. Like, I remember that well.
Oh, okay.
And so yeah, I was very happy that you were so interested in it.
Yeah.
So go ahead now. Okay,
Well, so then, you know, so finally, I think it was done. I forget the name of the maternal fetal medicine who was the head of that. So
Yeah.
I said, you know, they dragged me for about a year. And I said, I'm going to get it done with other physicians, family physicians if I have to, but we're going to get it done. And I stayed on there. So it was laborious. They wanted to put all kinds of contraindication just about canceling every woman who had a breech that could walk would not be eligible for vaginal delivery.
Yeah.
So, but finally
Finally
we had a good guideline, and I think it's 2008 or 9 that it was published. We'd have to check that.
2009.
Yeah, and then we encouraged to have. They were saying, most of the faculties of medicine were saying, well, we can't do it because there's nobody to teach it anymore. And that was not true, because there were physicians that were my age that believed in breech deliveries. So we had to, I made an editorial, time to consider breech vaginal delivery.
Yes,
So
yes.
I have the paper here.
And then,
Yeah.
I went to I don't know if you remember, I decided to leave the Figure job.
Okay.
Well, you decided that we couldn't afford me anymore anyway.
That's it.
So I go to
High paid experts.
Yeah. So what happened was, I said to you, I want to go to Europe, and I want to go to all the places where they do breech, and I want to find out what they're doing, what their protocols are, why they're continuing to do it. And you said, do you remember where you told me to go first?
No. France,
exactly.
Yeah. That's where I learned about doing VBACs, and not learn about doing it, but that's where it encouraged me to introduce in Canada VBACs. We were the first hospital in Canada, LaSalle Hospital, and for the first 100 women of VBAC, both the gynecologists and anesthesiologists came to stay in a hospital, because in them days there was no physician staying in a hospital during labor. So that's how we did, me and Claude Fortin, because everybody was telling us, if you have a mishap or something, you know, we're going to be against you. That's why I'm supporting doctors who have problems in the world, because you're always at threat of that.
So was that Port Royal that you went to?
No, I forget where it was. I think it was a big meeting of the French OB-GYNs, and it took me to a number of hospitals in the area of Paris.
Yeah.
I can't remember which one. Yeah, but they were the ones that were doing it.
Right. So then you managed to get the guidelines out. That's great. I want to ask you now today, what you know about what's happening in breech in Canada.
No, I don't have the statistics. Unfortunately, I don't have the statistics. I know that Sherbrooke, LaSalle were still doing breech vaginal deliveries, but I don't know about the other areas what they're doing. And I think Quebec City too is doing more and more. McGill was doing. When I was there, because we talked about it, and I was doing it at LaSalle, a few of the physicians at McGill followed to do breech vaginal delivery.
Do you remember also that I approached you about working on that article called Evolving Evidence Since the Term Breach Trial?
Vaguely, but I know that you were working on that.
It was about, it was a survey we did across Canada.
Okay.
Of all the obstetric units that had more than 3,000 people, or 3,000 births. And we were interviewing the head of obstetrics or the head of nursing to find out if they had changed their practice since the follow-up, the 2-year follow-up. And very few of them had. And
so what's the statistic now?
Well, the stats now are pretty low.
Yeah.
They're pretty low. There's not a lot going on. I mean, I tried to open up this hospital, as I said, in Toronto East General. They were open to it, but the midwives didn't want to bother the doctors too much. The doctors didn't want to do it. The midwives were interested, but it was during COVID. They just didn't continue it. We had our first successful vaginal breach, but one of the doctors came in, she didn't like it. It's like really like it. And so
Wow.
there wasn't much I could do. It just wasn't going to happen. But l'Hôpital Montfort, there they are.
Yeah.
It takes those French hospitals.
That's right. Oh yeah, no. University of Sherbrooke, all the residents are taught breech vaginal delivery.
Yeah, except that, you know what? One of the residents that came from there, that I know at Montfort, she stopped.
Huh?
Wow. I can't figure it out. It's
sometimes a physician has. I've had cases like that where physicians had a very bad complication, not due to them, but due
or
to
they
nature,
hear about it.
or they heard about it and
Yeah.
you get nervous.
Yeah.
You need to have some confidence to do a lot of things that we do in medicine.
Yeah.
I mean, even treating patients for day-to-day things. If you don't have confidence in yourself, you're not in the right profession.
Mm-hmm.
You need to have a good confidence backed by science.
Yeah.
And so the SOGC journal, I think, was very good for that. The editors, they could have nixed the paper and whatever.
Mm-hmm.
And they had me, and I wrote a guideline for them.
Yeah.
And that's how we got involved finally with bringing all the normal things to labor and delivery. And we had in LaSalle, we had every woman fill a little one-pager. What did she want during her labor and delivery? And I insisted to the medical records that be put in their medical record before her delivery. Because, in them days, we were starting then not to deliver all of all the women we were following, because everybody was going shifts, right? Coverage at night was group coverage, weekend coverage. So by doing that, for example, if I arrive and it's a woman I'm going to have assisting in labor and delivery, and it's a patient of my colleague, I have no idea about this woman. But by looking in one page very quickly, 2 minutes, I know she wanted to do squatting, she wanted this, that, whatever.
And she doesn't want the cord clamped.
So we never did that cord clamping very early. But it was, and I remember my most famous case with my nurses, which are always asking, okay, what is a Dr. Lalonde want to try out again? And so one day I told them, well, there's a Mrs. So-and-so, this is her name. When she comes in labor, she wants a labor and deliver standing up. Oh, well, I didn't get a good reception there. For about a month, they said they were just kidding me, you're just joking to us. I said, no, I'm serious.
Yeah.
So in comes the lady, and, I come in, I said to the head nurse, you see, on the chart? Yeah, she said, we don't know how that's going to happen. But problem, just, if she decides to walk, then go along with her and just have a nice clean sheet for the baby when it's going to be delivered.
Mm-hmm.
But she let me a little bit down because just as the expulsion came, she wanted to go on a kind of a rocking chair, So we laughed.
But you also did a study on upright
Yes.
positions for the phallic baby, not for breeches, but for phallic babies.
Yeah, the position mattered a lot, and we reduced our episiotomy rate. We reduced the forceps rate by 50% just by having a mobile.
Was that study at LaSalle?
Yeah, it was at LaSalle. We didn't publish this, I don't think.
Right.
Because I was very involved with FIGO, plus I had to, because I was in SOGC. The job in SOGC is a little tough because you got to raise the funds. We don't get government funds. I mean, the people of Canada don't realize that. The Pediatric Association, the Gynecology Association, the Surgeon Association get practically zero help from provincial and federal government. So I had to raise, millions of dollars because I had 50 employees, 14 on international, but 26 for different guidelines, implementation, the alarm program, etc.
Yeah.
So I was very busy in fundraising for 300 days out of the year.
How are they doing now that you're gone?
Oh, they did pretty good. I think there was a little dip onto their staffing ratio and everything for a couple of years, but now it's back on track, and they're actually having now support from the federal government, which I'm really impressed.
Aha.
Yeah, they have support.
Since when?
Since about 2 or 3 years now. On
During
maternal
Trudeau.
mortality monitoring. They have another, and you know they have a good relationship with the Minister of Health, whichever one was in the last 6 years with Trudeau, and they had pushed through, you know, that birth control pill should be free.
Right.
That's still happening, but now
Right.
they have to convince the provinces.
Right.
So no, they've had some good relationship there.
So I have a question for you that comes from Australia, and that is when I speak with Andrew Bissett, who he's the. Have you met Andrew?
I think I know the name, but I'm not.
So Andrew Bissett is the head of he's the medical lead for the maternity in the Royal Hospital for Women in Sydney, Australia.
Yeah.
And he's also continued to do breaches for forever. But he also had learned from a midwife, Maggie Banks from New Zealand, that it might be better in the upright position. So he actually started experimenting with that, and he's been using that for almost 30 years. And he says that, you know, for 27 years he hasn't needed forceps since he started. And that's what they're in Frankfurt. They're finding that like over half of the women deliver with
yeah.
They don't need it exactly. There's no maneuvers at all.
No, you just got to put your hands to receive the baby.
Yeah. But Andrew said that when there was a problem, when the term breach trial came out, and then it was the results showed that in fact there didn't appear to be actually any higher risk neurologically with the babies at 2 years. It was the insurance companies that did not want to cover it, and they were concerned about the physicians continuing to do breaches, and so they got in the way of physicians who did want to do it. In Australia. So
Okay.
my question to you is, did you feel that at all here?
No. And you know, I introduced, I think in 2000, I introduced this partnership with High Rock, which
Right.
is the insurer of hospitals.
Right.
And the agreement with High Rock is that their hospital would follow the guidelines of SOGC. And they never interfere with the guidelines. And we showed within 3 years 30 to 50% reduction in medical legal costs because of our programs.
Wow.
Yeah. So the alarm, it was called the More OB program.
The Moral B program.
Dr. Ken Mill, unfortunately passed away.
Mm-hmm.
I told him one day, look, you're going to just concentrate on this. And so build us up. It took a year or 2 years to build up the whole program. And it's still in existence.
It is still in existence, and actually I really appreciate it as a midwife because it was the first time, and I don't know if you remember, but it was coming in at a time when midwives were just getting legislated, and they realized we have all these rebellious women who are coming into the hospital. They've never practiced in the hospital. I didn't even know how to use an electronic fetal monitor. I had to learn how to do those things, and
because the beauty of the More OB program is that everybody's on the same level.
Exactly. Everyone gets together and talks about research, what the latest research is, and we all have to do it. And they even had lovely, I remember, signs that said, right in the program, the worst place for a woman to be in early labor is in the hospital. We always like them.
Never had pressure of the insurance. Well,
that's
don't forget that it's special in Canada. There's no other country that's. We're insured by a non-profit called Canadian Medical Protective Association. All the doctors are there.
Right.
And they don't, in general, interfere with the practice of medicine.
Right.
They sometimes I felt in the past they should have interfered because same physician kept having all the complications and they were still just insuring them and not asking any questions. But they were really hands-off in terms of the clinical practice. I think in the States, the insurance companies had big influences on the practice of medicine.
Right, so that would be more in that's interesting just as a model.
Exactly, the Canadians could be proud of that.
Yeah.
But the problem is that universities stopped teaching it, so that's a major problem. But it's not the first time that
stop teaching breach. Yeah.
It's not the first time that a big trial has led women the wrong way.
Right.
Like what happened with menopause. I mean, it's a big scandal.
Yeah.
Thousands and thousands of women have suffered unnecessarily. And now, instead of it being risky for breast cancer, a woman who has hormone therapy, it's actually reducing breast cancer in the ages of 35 to 55. So, the whole system come around. But Ken Mill used to say, that, you know, randomized trials are good, and you should try to always practice evidence-based medicine, but you have to qualify that. And you have to realize that sometimes, you know, your own expertise, if your own expertise and your practice doesn't show that, then you have to start to make questions.
Well, and what Kent's advice as an epidemiologist is, you can also use observational data.
Well, that's
So
what
if
I
you're
mean, yeah.
so and what you're talking about is at LaSalle and your own practice, and in the team that you have at LaSalle, if they're doing well, then that probably counts for more than following a randomized control trial, which has been done over the world in a lot of different places in a lot of different ways. So it's really, really important to do your own data collection.
Well, because I learned, not from epidemiology, but when I did my training in economics, they fix all the parameters. Medicine, you can't fix all the parameters.
Right.
Every woman is a parameter
Yeah,
in
yeah.
itself. So,
Yeah.
you know, that's why there is a lot of errors that happen and goes and comes back, you know, like mammography, should you do it, should you not do it? And you use huge studies. But you always got to remember that experience is also very important. And, you know, when we introduced at LaSalle, first hospital, introduced the ligands treatment to prevent, you know, the terrible disease of the premature babies. They were, you know, I can remember at the Royal Victoria Hospital, a level 3 hospital, have 30 babies intubated at a time. And when we start using the corticosteroids, it went down to 1 or 2 babies.
Mm-hmm.
And people would come in and say, well, you know, we want to do another study. I said, well, yeah, do another study. You know,
It's here.
this is obvious, you know.
Mm-hmm.
It's not like, you know, one day we have 10, the next day we have 8. No, we had 30 beds, and now we have 1 or 2 beds.
Mm-hmm.
And so we endorsed this very quickly at McGill University. But some people went on and on to do studies on it.
You know, the other thing that happened, I remember around the time that I was still working with you, is that there was a maternal mortality at the General Hospital, and it was following a breech delivery.
General Hospital in Ottawa?
Yeah, and it was a breech delivery that was done by cesarean, and it was a woman from the Congo. And
Oh, yeah, I remember that. Yeah, yeah.
Do you remember?
She had 4 C-sections and they were all okay. And then, wasn't that a
No, she had all of the babies born vaginally.
vaginally?
Like
And then,
at
you,
home,
yeah, and then you
in-
decided
like
to do it's the
in
reverse.
Africa.
Yes.
And she comes here, it's her first baby, and that she'd had bisection, and it was breech, and that's why she had it. And there was a big question about why you would do that, and it was 2005, so it was after the follow-up to the term breech trial, which had exposed the fact that in high-resource countries, it actually looks like it's very similar.
Exactly.
Whether you're going to have a section or a non-section, but for the mother it makes a big deal. Like whether you're going to have a section or not section for the neonate, it's not that much different, and for the mother it's huge to have a section instead of having a vaginal birth. So that's what was very sad about that case, I think it really set our city into a bit of a spin. And it certainly sent me into a spin. That's why, again, I went down to you and I said, we got to do something about this. And I was so happy you did. So thank you.
You're welcome.
Now, I'd like you to just say something now about why, just in general, about why, because this is just going to be a little spot we're going to do. At the very beginning of our program, we're creating this thing called the Breech Power Course. And POWER stands for a package of online learning, workshops, 2-day workshop. E stands for experience, and we're going to send people to Frankfurt and Brazil and various places where there's a bit more high volume. And R stands for peer review, and review of systems, and review of your protocols, and exchange among people, which we can do on Zoom. So we're going to do this whole course in Canada. And we are also, as part of this course, we've created actually a National Breech Society of Canada. It's one of its first things we thought we might do is create something called the Breech Friendly Hospital.
Yes. Well, you should come with us in the
Well,
Mother Baby
exactly.
Family Friendly Hospital.
Exactly. I thought, okay, we should just kind of tie this in, right?
Yeah.
But what I want to ask you, I just want you to say in just a few words why you think you we should continue to do vaginal breaches in Canada, because there are many people who think we shouldn't.
Yeah.
Right. So just from everything you said, just a short.
Well, I think we're now realizing, since this is happening now for 10, 15 years, that there's serious complications of postpartum hemorrhage with repeat cesarean sections. Very serious. Where then women have hysterectomy, they may use their ovaries, they're 26 years old. This is really, against the principle of do no harm. As a physician, I'm trained to do no harm if I'm supposed to do something. So I think, this was really not understood well, because a lot of the countries where they had a high cesarean section rate, they had one baby, sometimes two, but most of the time only one, like for example in Brazil. But in other countries where women, and today you're seeing the families are getting bigger. We notice that in traveling. A lot of women, a lot of people are traveling, 2 kids, 3 kids, even 4 in the city of Ottawa. I see them often. So then if they're going to have 2 or 3 or 4 cesarean sections, they're very high risk. Very high risk. Placenta previa, placenta accreta is up to the sky. And, when you read the reports of what these women undergo, hysterectomy, massive transfusion, close to death, that's the answer. The answer is definitely you should not do something that could lead to, because you cut their choices. I mean, a woman doesn't have a choice after, because she has to think, look, I have a husband, I have a child, I have 2 child. Really, do I should take a chance for a 3rd child and have these complications? So I think that's the main reason. It's, you're creating a system for complications, which is against my principles and the principles of medicine, I think.
Right. So how do you feel about us starting a breech course?
Oh, I think it's good. It should be for all the health professionals, the midwives, the nurses, the doctors, the family physician, the gynecologist, and that would get a movement. And I think the movement needs a couple of key women in society, in Ottawa or in Canada, to be the promoters. Mm-hmm. If we get a star of TV or something that would say, this is the way to go, then that would start a following. That's what you need. I mean,
okay, that's what we need. We need a movie
the social program and social networking. That's what we need.
Yeah.
And work with. We're trying to energize the Canadian Foundation for Women's Health, and that would be something that they should take on. And I think you need official training in all medical schools, all the nursing schools, and all the midwifery schools.
All right, so I'm going to send you the template that we've made up for the Breech Friendly Hospital, and maybe you can run it by your people at your organization, and we can just add it onto your plate.
Yeah, because we do a lot of things. For example, we do now positions. We do, we do our seminars on a whole bunch of things now. We're having seminars just about every 2 weeks, free seminars, because online doesn't cost anything. We're pulling people from all over the world. So, that could be one.
Great.
That could be definitely one.
Okay.
All right.
And then we'll talk about Ricardo off camera.
Okay. Thanks. Now you got to fix everything that we took before I get kicked out of the house by my wife when she gets back tomorrow.